Good afternoon, everyone. My name is Ed Kinsella. I'm the Secretary for the American Bladder Cancer Society, and I'd like to welcome you all this afternoon. We have Dr. Jason Estafiou with us this afternoon. He's going to speak on the bladder sparing protocol at Massachusetts General Hospital for invasive bladder cancer. And we'd like to welcome the doctor with us this afternoon. He has a short presentation for us. I asked him before he started if he minded taking questions during the presentation. If folks would like to submit questions, if you could just type them into your questions panel, I will monitor them on the computer and then we can provide it to the doctor. We have the audio response from the participants muted so that we don't get feedback from various devices. So if you do have a question for Doctor, just type it in and we'll relay it to him and we'll get an answer. So with no further ado, I'd like to introduce Dr. Estafiou to you folks this afternoon. Doctor?
Great. Thank you very much. And also thank you for the invitation by the American Bladder Cancer Society to talk about bladder sparing therapy. This is a nice opportunity, and as was said, I'd be happy to answer questions during the presentation as well. So I am a radiation oncologist at Massachusetts General Hospital and work with a large collaborative multidisciplinary team on, if we can go back, a large multidisciplinary team taking care of bladder cancer patients. And so again, today I'll be focusing on bladder sparing therapy. Organ conservation, or the preservation of an organ, is actually now commonplace in oncology in general. With a number of cancers, that being the primary modus operandi. So anal cancer, breast cancer, breast conserving therapy, esophageal cancer, cancers of the larynx, sarcomas. Prostate cancer has options where radical surgery are not needed, and this indeed now applies to bladder cancer. So in bladder cancer, cystectomy has been the gold standard. Though alternatives have emerged in the last few decades aimed at bladder conservation. The goals between either cystectomy or bladder preservation are the same. Number one, we want to cure the patient. We want to optimize survival. We want to prevent failure and recurrence. And we want to provide good quality of life with what we would call a functional urinary reservoir. So what is that modern alternative to a radical cystectomy? It's what we call trimodality therapy. And it really is an important combination of treatments. So a maximal transurethral resection of the bladder tumor, what we call a TURBT, is needed. Ideally, this is visibly complete, meaning that the urologist, when they have done that resection within the bladder under cystoscopic guidance, that they actually don't see any residual cancer left. Then radiation therapy along with chemotherapy is used. Next slide, please. And here's sort of a schema of bladder sparing therapy. It starts with a transurethral resection, as I mentioned, and then a course of radiation and chemotherapy, a break for a few weeks, and then another look by the urologist by cystoscopy, asking the question, is there any tumor there? Is it persistent? Has it recurred? And if it hasn't, we continue with what we call consolidation chemoradiation to a full dose of radiation. If, however, there is evidence of persistent or recurrent tumor,